I thought I would shoot a video just showing how I evaluate motion throughout the foot and ankle. And of course these joints are very different. You know, the ankle joint is very different than the joint below that, the subtalar joint. Very complicated joint. Ankle joint mostly moves, moves the foot up and down. Little bit of rotation available, but not much. Little bit of medial and lateral motion. Whereas the joint below that, the talocalcaneal joint or subtalar joint, has a transverse plane rotation, but also inverts and everts. Then the midfoot has a lot of medial and lateral rotation. Okay, a little bit of up and down motion as well. Then the metatarsals primarily move up and down. So very, very different joints. And then the fibular joint down here is a very different joint, and at the very top of the fibula as well. So I first test passive ankle dorsiflexion, and I do that on both sides to compare, and I test overpressure. And I also test posterior glide of the talus. I test posterior glide of the distal tibia. I test external and internal play of the tibia, very small motion there. Okay, and then I come and I leave a finger's width to come onto the navicular, and then I test traction of the midfoot. I test up and down glides of the midfoot. I test downward rotation or pronation of the midfoot, primarily the navicula and the cuneiforms. And then I can get more specific, and I can test superior and inferior glide of the cuneiforms and of the navicula. Same thing for metatarsals. And of course it's important to have toe extension, big toe extension for step off during the gait cycle, so I evaluate that as well. I evaluate traction of the fifth metatarsal. Sometimes in a ski boot or a skating boot it'll get stuck posteriorly and become painful. I also test upward and downward mobility of the cuboid. Okay. I test superior spring mobility of the fibula, and I can also capture the fibular head, and I can test inferior spring, and there should be the slightest amount of give there, the slightest amount when I spring the lateral malleolus posteriorly. It should have a very strong feel but a tiny bit of yield, and same thing with capturing it behind the malleolus and gliding that forward. And then I test the fibular head, and it's a prominent little bump here on the outside just below the patella. Here's the knee joint, and it's about 2 inches below that. And I test posterior glide. Extremely rare for that motion to be restricted, but somewhat frequently you'll find it restricted in terms of anterior glide. And I spring it a little bit laterally to allow a little bit of distraction in that joint, but she has good play. So anyway, that's a summary on a real person on how we screen foot and ankle motion. And yesterday, this client presented with restricted dorsiflexion on the right side, and we mobilized that talus posteriorly and in rotation as well. She had a lack of pronation movement of the midfoot on the left, and we restored those motions as well. Today she's walking a lot faster and a lot freer. Has some arch soreness on the right, and I think it's just the foot adapting to new movement. Did not find any restriction today in either side. But anyway, I hope this is a little bit informative on testing on a real person versus the demonstrations I've done on the skeletal foot model. Thank you.